with the 2 to 3 or another 2 to 4 hours. If you're worsening vital signs and rapidly rising the hematocrit, then increase the rate to 5 to 10 milliliter per kg per hour for 1 to 2 hours. So once again, the 7 to 10, so you can switch it over, make it increase whenever the hematocrit is not decreasing, means a sudden increase. So reassess the clinical status, repeat the hematocrit, and review the fluid infusion rates accordingly. Reduce the intravenous fluid gradually when the rate of plasma leakage decreases towards the end of the critical phase. This is indicated by adequate urine output or fluid intake and hematocrit. So my dear, you have seen that the hematocrit is a crucial in the management of this stage B, my dear. So yes, B equal to 2 to 3, 2, 3, 5, 7, 10. Say with me, 2, 3, 5, 7, 10, 2, 3, 5, 7, 10, 2, 3, 5, 7, 10. In contrast, going back to the right, going to the C group, before going to the group C, the monitoring of the treatment, yes, the temperature pattern, urine output, warning signs, hematocrit, once again vital signs, urine output, hematocrit, blood sugar, other organs, functions. Yes, because they can turn into the critical or severe dengue. Treatment of compensated shock is the start IV fluid resuscitation with the isotonic crystallite solution. So once again, the crystallite is a one important message, my dear, 5 to 10. Over 1 hour. Reassess the patient's conditions, and if the patient improves, then you get down 5 to 7 for 1 to 2 hours, 3 to 5 for 2 to 4 hours, and 2 to 3. So the same here, group B. If the patient is still unstable after giving the 5 to 10, the check the hematocrit, start the 5 first bolus. The hematocrit increase is still high, more than 50%. Repeat the second bolus of crystallite of 10 to 20. So you top up from 5 to 10, then 10 to 20. If it improves after second bolus, reduce the rate, once again getting down to 10 to 7, 1 to 2 hour, continue to reduce as above. So hematocrit decrease that increase indicates bleeding and needs to cross-match and transfuse the blood. So this is one of the important information, the when the hematocrit decreases, the blood transfusion. So the box for the C equal to. So paxil volume is the guiding. So whenever the paxil volume, yes, it increases, we need to start the fluid therapy. So IV crystallite is the treatment. And these IV crystallite that starts in the C group of peoples is a 5 to 10, 10 to 20. This is very important, my dear, the 5 to 10 and 10 to 20. So you can remember the 5 to 10, then 20. And if the responses are good, then you can come down from the 10 to 7, then to 5, depending on the paxil volume. So I know the yes, the paxil volume is decreased. That does mean the paxil volume you have to replace by the blood transfusion. The BT is the treatment of choice. So treatment of hypotensive shock, the starts here means that decompensated shock. Hypotensive shock means decompensated shock. The same here. So you need to be very, very careful. The C stays, the PCV increase, but these, once again, there is the compensated shock. You are managing the compensated shock. But in contrast, if you're non-compensated shock, yes, or hypotensive shock, that you should start the crystallite from the 20. So this is the crystallite fluid. Yes, the crystallite it is written equal to 20. You should start from the 20 as a bolus from 15 minutes. If it is not working, then colloid for 10. Yes, over 1 hour. Then reduce gradually, and once again it depends on the, you see it is written hematocrit was low, then indicates bleeding, then needs a cross match, high compared to the baseline, then change to the IV colloids. Once again 10 to 20 as a second bolus, and improving, reduce the rate 7 to 10, same, just like the uncompensated shock. So yes, my dear, the summary talk for the compensated shock that starts with the crystalloid fluid. There is a 5 to 10 to 20. You can increase based on the backcell volume, and backcell volume decrease the same both cases. The blood transfusion for the non-compensated shock starts with the crystalloid first bolus, the 20, the rate at the rate of 20 over 15 minutes. If it's not working, then go for colloid with the 10. Once again, it is written that once again another the second bolus. If it is not working, once again the colloid equal to 10 per 1 hour. And if it is improved, then you can go for crystalloid fluids once again. So yes, my dear, it starts with the crystalloid, then colloid, then colloid. Crystalloid, colloid, colloid, crystalloid, colloid, colloid. Means the first crystalloid, then colloid, then colloid. Then if it improves, then come back to the crystalloid. So these are hypotensive or non-compensated shock or uncompensated shock, but for the compensated shock is a crystalloid fluid. So yes, the discharge criteria, all of the following criteria must be present: no fever, improving the clinical picture, increasing trend of the platelet count, and also no respiratory distress, and stable hematocrit without intravenous fluids. The summary talk here that we made a box with the B groups, the crystalloid fluid and normal saline. That will be based on the hematocrit levels, the 2 to 3 to 5, 7, 10. 2, 3, 5, 7, 10. In contrast, the non-compensated here starts with the compensated shock starts with the crystalloid, and that should be started with the 5, 10, 20. But once again, if non-compensated or hypotensive shock starts with the 20 over 15 minutes, and colloid 10 over 1 hour, and colloid 10 over 1 hour. Treatment according to the group A to C, National Guidelines for the Clinical Management of Dengue Syndrome. Regarding the group A, this patient will be advised to adequate bed rest, adequate fluid intake, more than 6 glasses for an average sized adult. According to children, milk, fruit juices, cushion with the diabetic patient, oral rehydration solution, ORS, barley, rice water, coconut water. Plain water alone may cause the electrolyte imbalance, not the plain water. Take the paracetamol not more than 3 grams per day for the adults, and 10 to 15 milligram per kg per dose, not more than 3 to 4 times in 24 hours in children. Tepid sponging. Look for mosquito breeding spaces in and around the home. Eliminate them, and this patient will be advised avoid aminosalicylates, is aspirin, mefenamic acid, ibuprofen, means all the NSAIDs and steroids and antibiotics. If any of the following is observed, the patient should be immediately taken to the nearest hospital. The warning signs for the danger, as we already learned, for the warning signs are the A, B, C, and the 3 else minor that you need to know. So bleeding manifestations and the other features of all the warning signs. So these group of peoples are managed at home and with the adequate bed rest and fluid intake as much as possible with the paracetamol only, and they should avoid the aspirin and all the NSAIDs and of course the steroids and antibiotics. The group B, the managing patients, the group B, obtain a reference hematocrit before the intravenous fluid therapy. It means the paxil volume will guide you the management planning. Indications of IV fluid: when the patient cannot take the adequate oral fluid, when the hematocrit rises 10 to 20% despite the oral rehydration, impending shock or shock. The general principles for the fluid therapy in dengue hemorrhagic fever include the following. The following fluids are recommended, both the crystalloids and colloids. Crystalloids are the 0.9% sodium chloride, preferable 0.45% half strength normal saline solution for the children, and dextrosine ringer, lactate ringers, and also dextrosine acetated ringers, and Hartmann solutions preferable. So yes, the crystalloid and colloids are the dextran, hemaxyl, plasma, and blood components, and human albumin. Isotonic crystalloid solutions should be used throughout the critical period. Yes, the isotonic crystalloid solutions, except in the very young infants less than 6 months of age, in whom 0.45% sodium chloride may be used. Give only isotonic solutions such as 0.9% saline, Ringer's lactate, or Hartmann's lactate solution. Hyperoncotic colloid solutions like the osmolarity more than 300 milliosmol per liter such as dextran 40 and starch solution may be used in patients with massive plasma leakage and those not responding to the minimum volume of crystalloid. Here's the dextran 40 and starch for the massive plasma leakage, yes, and those not responding to crystalloid. Isoonconic colloid solutions are blood and blood component may not be as effective. Isoonconic colloid solutions such as blood and blood component may not be as effective. This is another important information. By volume of about maintenance plus 5% dehydration should be given to maintain the just adequate intravascular volume in circulation. The duration of intravenous fluid is the 24 to 48 hours, means the plasma leakage period is a critical period. We call it as the 2 days, my dear, with shock. However, for the patients who do not have shock, and the duration of intravenous fluid may have to be longer, but not more than 72 hours, means not more than 3 days. And this is because the later group of the patients that just entered the plasma leakage period, while shock patients have experienced a longer duration of plasma leakage before intravenous service began. In obese patients, the ideal body weight should be used as a guide to calculate the fluid volume. The fluid requirement both the oral and IV in critical phase 48 hours calculated as M plus 5%. M means maintenance plus 5% deficit. So maintenance and 5% deficit is calculated as 50 ml per kg after 50 kg. Here is an example is given the calculation normal maintenance of the intravenous fluid infusions. So maintenance is the 4 ml per kg per hour for first 10 kg body weight and 2 ml per kg for next 10 kg body weight, and once again 1 ml per subsequent kg body weight. For overweight or obese people, they calculate normal maintenance fluid based on ideal body weight using the following formula. Yes, my dear, you can see and you can use them, and guidelines, see them. And here is some examples for the children is given so that you can see them. Fluid management of the patients for the group B. In general, the fluid allowance oral plus IV is about maintenance for 1 day plus 5% deficit or an IV fluid together to be administered over 48 hours. This is the message 48 hours. For example, in child weighing the 20 kg, the deficit is the 5% is 50 ml, so 1 liter. The maintenance is 1500 ml for 1 day, hence total is a 2.5 liter. So yes, this volume is to be administered over 48 hours in non-shock patients. The rate of IV replacement should be adjusted according to the rate of plasma loss, guided by clinical conditions, vital signs, urine output, and the most important, the paxil volume. The admitted patients like the category B should be started recommended fluid at a rate of 1.5 ml per kg per hour or 40 milliliter per hour for adults and should be given for 6 hours. Yes, my dear, this is the message. If patient's vital signs are stable and the escalation of the fluid is not needed, then the same rate can be maintained for a period of 48 hours. Then 2 days should be maintained the same rate. And that can be increased from the 1.5 to 3 milliliter to 5 milliliter to 7 milliliter. If every 6 hours doesn't have the stable vital signs or urine output, to every 2 hours with a special attention to the vital signs, urine output, respiratory signs, and hematocrit. In 6 hours escalation, if the patient is stable. Regarding critical parameters, they decline from the 7 to 5, then up to the at least 48 hours. So the summary talk for the 1.5, then 3, 5, 7, and then you can go up to 10, but this is enough. So he's also written, the previous box with a 2, 5, 7, 10, or 1.5, here's 1.5, 3, 5, 7, 10. So this is the box, my dear. So once again, this is the fluid management of the dengue shock. So you can use the fluid and you can see the rate of IV fluid in the children and rate for adults, type, total hematocrit, and urine output. So that, yes, you start with the 1.5, then 3.5, then 7, then getting down to the 5, then 3, then 1.5. So reassess the critical status, repeat the hematocrit, and review the fluid infusion rates accordingly. Patients with warning signs should be monitored by health care providers until the period of risk is over. A detailed fluid balance should be maintained. Parameters that should be monitored include the vital signs, peripheral palpitations, urine output, hematocrit, blood sugar, and other organ functions such as renal functions, liver profile, coagulation profiles as indicated. Platelet transfusion is not recommended for thrombocytopenia. This is the message once again. The indications of which may be as follows: severe, very severe thrombocytopenia who need urgent surgery. Yes, the platelet who need the surgery, the circle, the surgery, the platelet transfusion. The clinical judgment of treating physician. If the platelet concentrate is not available, fresh whole blood may be transferred as per guidelines given under the DGHS management. Yes, my dear, only before the surgery and clinical judgment of the treating physicians. If the patient has dengue with the coexisting conditions but without warning signs, the action plan should be as follows: encourage oral fluids. If not tolerated, start IV fluids 0.9% ingress with or without at the appropriate maintenance rate. Use the ideal body weight for calculation of the fluid infusion. Give the minimum volume required to maintain good perfusion, urine output. IV fluid size will usually needed for only 48 hours only. And the patient should be monitored by the health care providers for the temperature pattern, volume of fluid intake losses, and urine output, warning signs, hematocrit, white blood cell, platelet counts. Depending on the clinical pictures and facilities of the hospitals and the health care, other laboratory tests can also be carried out. So this is the monitoring data: onset of fever, the daytime hematocrit, temperature, WC, and platelets. Patient monitoring chart and the national guidelines based on them. And also once again is the temperature, respiratory, crystalloids, colloids, blood products, volcanic, yes, input and output as well as urine and urine. So yes, laboratory results should be tabulated under the time of blood sampling, time of results being available. Group C, yes, the critical and severe dengue. The goal of the fluid resuscitation include the starts from the, yes, the 10 to 20. Yes, it is written that the compensated shock starts with the crystalloids, then 10, then go up to the 20. But for the non-compensated, means the hypotensive shock, they starts from the 20, from the crystalloids, then colloids, then colloids. But here the laboratory investigation, the ABCs, the another mnemonics that you need to remember. A for acidosis, B for bleeding, C for calcium, and S for blood sugar, should be carried out in both shock and non-shock cases where no improvement is registered in spite of adequate fluid replacement. Acidosis, it is the blood gas, the capillary arterial blood gas analysis. Cirrhosis, arterial blood gas analysis should be done to indicate the prolonged shock Organ involvement should also be looked into, the liver function and blood nitrogen, creatinine, and bleeding. The hematocrit, if dropped in comparison to the previous value, not rising, the cross match, and for the rapid blood transfusion should be done. And see, for calcium electrolytes, the calcium hypocalcemia is found in almost all cases of DGHS but asymptomatic. Calcium supplement in more severe and complicated cases indicated. The dosage is 1 milliliter per kg, diluted 2 times IV push slowly, and may be repeated every 6 hours if needed. Maximum dose is 10 milliliter of calcium chloride. And as for sugar, the blood sugar, both hyper and hypo, can be happening in both cases, most severe case of the DHF. So poor appetite together, vomiting, dosing, impaired liver function, hypoglycemia, and some with hyperglycemia. So yes, why do the cirrhosis, bleeding, see for calcium, and as for sugar, acidosis, bleeding, calcium, sugar, acidosis, bleeding, calcium, sugar. So ABCS. The management of decompensated shock, once again this starts, you see the hypertension, this starts with the 20 crystalloid, then goes down to another colloid, then colloid, and also the cause of ABCS. Always look for, in case acidosis, hyperosis, Ringer's lactate should not be used. And hematocrit measurement every hour, yes, is more important than platelet count in the management. Highest dose of colloid should be the 30 ml per kg per 24 hours. So this is once again the flow chart is given for the volume replacement with the dengue shock syndrome. As I said, the compensated and decompensated shock. This is one of the important talk when to stop the intravenous fluid therapy. Cessation of the plasma leakage, stable BP means all the features of critical major warning signs are lessened so that you can. And treatment of hemorrhagic complications. Patients at risk of severe bleeding are those who, and severe bleeding should be recognized in the following situations. Hemorrhagic complications have profound and prolonged refractory shock, have hypotensive shock, multi-organ failure, are given non-steroidal agents, have pre-existing peptic ulcer disease, are on anticoagulant therapy, have any form of trauma including intramuscular injections. Severe bleeding should be recognized in the following situations. Persistent severe overbleeding in the presence of unstable hemodynamic status, decrease in hematocrit after bolus of fluid, which is unstable hemodynamic status. So somebody talk is a hemodynamic status, a refractory shock that fails to respond, consecutive fluid resuscitation, hypertensive shock, inappropriately low normal hematocrit, persistent worsening metabolic acidosis, and well-maintained systolic PH, especially in those with severe tenderness and distension. The action plan for the treatment of hemorrhagic complications. If possible, attempts should be made to stop bleeding if the source of bleeding is identified. Severe epistaxis can be controlled by nasal adrenaline packing. So nasal pack. Give aliquots of 5 to 10 milliliter of the fresh packed red cells. The pack cell volume of 10 to 20 milliliter per kg of fresh whole blood at an appropriate rate, and observe the clinical response. It is important that the fresh whole blood or fresh red cells are given oxygen inhalation 2 to 4 liter. Consider whole blood. Consider repeating the blood transfusion, the further overt blood loss or no appropriate rise in hematocrit after blood transfusion in an unstable patient. There is no evidence that supports the practice of transfusing platelet concentrations and fresh frozen plasma for severe bleeding in dengue. Transfusion of the platelet concentration of the fresh frozen plasma in dengue and not able to sustain the platelet counts and coagulation profiles. Instead, in this case, the massive bleeding, they often exacerbate the fluid overload. This is a very important information, my dear. Yes, so the platelet transfusion and fresh frozen plasma, the box. So the box here, in case of bleeding or hemorrhagic or bleeding manifestations. Why there isn't bleeding? So the platelet or plasma, means the fresh frozen plasma, FFP, is not indicated. Yes, my dear doctor. In GIT bleeding, the ACE2 antagonists and proton pump inhibitors, and great care should be inserting the NG tubes and bladder catheters and lubricated orogastric tube. Minimize the trauma during insertion of the central venous catheter down the ultrasound guidance. And essential, remember the blood transfusion is only indicated in dengue patients with severe bleeding. Only severe bleeding. Yes. Glucose control. Hypoglycemia may occur in same patients at a different time during the critical phase. Hypoglycemia, so it increases morbidity and mortality in critically ill patients and pediatric patients. Hypoglycemia may cause the seizures, mental confusion, and unexplained tachycardia. Most cases, hyperglycemia will resolve with appropriate isotonic, non-glucose, and adequate fluid resuscitation. In infants and children, blood sugar should be monitored frequently during the critical phase and into the recovery phase if the oral intake is still reduced. Hyperglycemia is persistent. Undiagnosed diabetes mellitus, impaired glucose tolerance should be considered, and IV insulin therapy should be initiated. Hypoglycemia should be treated with emergency 0.1 to 0.5 gram per kg glucose rather than glucose-containing resuscitation fluid. Frequent glucose monitoring should be carried out. Euglycemia should be maintained with a fixed rate of glucose isotonic solution and enteral feeding if possible. So here's the glucose control. Is a hyper and hypoglycemia is the same protocol. Is a yes, as we do in the other patients. Electrolyte and acid-base imbalance, hyponatremia, is a common observation. So here's the use of isotonic solution resuscitation will prevent and correct this situation. Hyperkalemia observed in severe metabolic acidosis and acute renal injury. Appropriate volume resuscitation reverse the metabolic acidosis and associated hyperkalemia. Life-threatening hyperkalemia in the setting of acute renal failure can be managed to resonium and infusions of calcium gluconate and also the insulin dextrose. Renal support means, as in the other cases, the hyperkalemia management. Renal support may have to be considered. Hypokalemia is often associated with GIT fluid losses and stress-induced hypercortisol state. It should be corrected with the production of supplements in the parenteral fluids. Serum calcium levels should be monitored and corrected when large quantities of the blood have been transfused or if sodium bicarb has been used. Metabolic acidosis, compensated metabolic acidosis, is an early sign of hypovolemia and shock. Lactic acidosis due to tissue hypoxia and hypoperfusion is the most common cause of metabolic acidosis in dengue shock. So yes, the lactic acidosis is the most common cause of metabolic in dengue shock. Correction of the shock and adequate fluid replay will correct metabolic acidosis. If metabolic acidosis remains uncorrected by this training, one should suspect the severe bleeding and check the hematocrit. Transfuse the fresh whole blood, fresh packed cells urgently. Sodium bicarb for metabolic acidosis caused by tissue hypoxia is not recommended for pH more equals 7.10. Bicarbonate therapy is associated with sodium and fluid overload, an increase in lactate and partial carbon dioxide, an increase and a decrease in sodium ionized calcium. A left sheet of oxygen hemoglobin dissociation curve may aggravate the tissue hypoxia. So somebody told the sodium bicarb shouldn't be used. Hyperchloremia caused by admission of large volumes of sodium chloride. Isolation may cause the metabolic acidosis in normal lactate levels. And if serum chloride levels increase, use the Hartmann solution or Ringer's active crystal. They don't increase the lactic acidosis. Signs of recovery: the pulse, blood pressure, breathing rate, normal temperature, no evidence of external internal bleeding, return of temperature, no vomiting, no abdominal pain, good urinary output, stable hematocrit at the baseline level, convalescent, confluent, fatigue, rash, or itching, especially on the extremes. Yes, some of the recovery phase, some of the rashes. Diagnosed discharge criteria: no fever for at least 24 hours without the usage of antipyretic drugs. At least 2 days have elapsed after recovery from the shock. Good general condition with improving appetite. Normal hematocrit at baseline value or around 38 to 48%. When baseline value is not known, no distress from pleural effusion, no ascites, platelet count has risen above the 50 lux, and no other complications. One of the important dilemmas sometimes the facing the fluid overloaded patients. Some degree of the fluid overload is inevitable in patients with severe plasma leakage. This skill is in giving them just enough IV fluids to maintain the adequate perfusion and at the same time avoiding excessive fluid overload. So this is very critical stage, having a plasma leakage, and as a doctor that you are giving IV infusions. So a good balance is needed, giving IV infusions, having a plasma leakage, leading to fluid overload. So cause of excessive fluid overload are excessive or too rapid IV during the critical phase. So this is very important, excessive or too rapid IV. Incorrect use of hypotonic crystalline solution, another is the hypotonic solution. Inappropriate use of large volumes of IV fluids in patients that unrecognized severe bleeding. Large volumes. Inappropriate transmission of the fresh frozen plasma, platelet concentrates and cryoprecipitates. Prolonged intravenous fluid therapies. So the prolonged intravenous continuous IV fluids after plasma leakage has resolved means more than 48 hours from the start of the plasma leakage. Comorbid conditions such as congenital or ischemic heart disease, heart failure, chronic lung renal disease. So these are the cause of excessive fluid overload. So excessive, too rapid, hypotonic, large volume, prolonged, comorbid, along with the fresh frozen plasma, platelet, and cryoprecipitate. So one of the box for the fluid overload causes boxes are the most important talk, the platelet, transmission, fresh frozen plasma, and cryoprecipitate. So these three P's, along with that prolonged, rapid, excessive, and also hypotonic solutions and large volume solutions and comorbid conditions. Clinical features are rapid breathing, suprasternal indrawing and intercostal recession, respiratory distress, difficulty in breathing, wheeze crepitations, and large prolifications, tensilitis, persistent abdominal discomfort, pain or tenderness, and this should not be interpreted as warning signs of shock. And increased jugular venous pressure, pulmonary edema. The danger is the pulmonary edema. The cough with the pink frothy smoke and wheezing, crepitation, cyanosis, this may be mistaken as the pulmonary hemorrhage, irreversible shock, heart failure, often in ongoing hypovolemia, puffy face, and leg edema. The additional investigation needed are ABCs, the blood gas, lactate analysis, chest X-ray, cardiomegaly, proliferations, features of heart failure, ECG, to exclude the ischemic change, arrhythmias, and echocardiography to assess the left ventricular function, cardiac enzymes. Pulmonary edema, we need to exclude the heart failure due to the primary heart disease, so that we can say this is fluid overload due to the causes in dengue fever or precipitating factors in dengue fever. So additional investigations and management of the fluid overload, review the total intravenous fluid therapy clinical course and check and correct for the ABCS. All hypotonic solutions should be stopped. Yes, switch from the crystalloid to colloid solution as bolus fluid. So the colloid Dextran 40 is effective as 10 ml per kg bolus solution, but the dose is restricted to 30 ml per kg per day because of its renal effects. So here's the fluid overload, the treatment, the box, my dear. Yes, the ABCS. So you need to remember ABCS and then C for colloid is the treatment of choice, and that is nothing but the D for Dextran 40, and that should be at the rate of at the rate of at the rate of 10. That should be remembered. And in this stage, the IV furosemide may be administered if the patient has a stable vital signs, if the patient is in shock together with the fluid overload. 10 minutes of colloid dextran should be given. While the blood pressure is stable, usually within 10 to 30 minutes, administer 1 milliliter of furosemide and continue with infusion of the dextran until completion. IV fluid should be reduced to as low as 1 milliliter per gram until the hematocrit decreases to the baseline or below. The following points should be noted. This patient should have a urinary bladder catheter to monitor the urinary output. IV furosemide should be administered during dextran infusion because the hyper-oncotic nature of the dextran will maintain the intravascular volume while furosemide depletes the intravascular compartment. After administering furosemide, the vital signs should be monitored every 15 minutes. Yes, for 1 hour to note its effects. If there is no urine output in response to furosemide, check the intravenous volume status, and if this adequate prerenal failure is excluded, implying that the patient is in acute kidney injury state. This patient may require the ventilator support zone. If the intravascular volume is inadequate or the blood pressure is unsustainable, check the ABCS and other electrolyte imbalances. In cases with no response to furosemide, so in response to furosemide, no urine output, and in cases with no response to furosemide or no urine obtained, repeated dose of furosemide, doubling dose are recommended. Oliguric renal failure established, renal replacement therapy is done as soon as possible. Pleural or abdominal tapping may be indicated, can be life-saving in some cases. Severe respiratory distress and failure of the above management. This has to be done with extreme caution because the traumatic bleeding is the most serious complications, can be detrimental. Discussions and expansions about the complications and the prognosis of the families are mandatory before performing this procedure. Management of encephalopathy. Some dengue fever and dengue hemorrhagic fever patients present unusual manifestations, the signs and symptoms of the central nervous system involvement, such as convulsions and coma. This has generally been shown to be encephalopathy, not encephalitis. So this is encephalopathy, not the encephalitis, which may be result of intracranial hemorrhage or occlusion associated with the DIC or hyponatremia. Most of the patients with encephalopathy are reported to have the hepatic encephalopathy. Here's the word, the hepatic encephalopathy. The principal treatment of the encephalopathy is to prevent the increase in intracranial pressure. So radiological imaging of the brain is recommended if available to rule out the intracranial hemorrhage. The following are recommended supportive therapy for this condition. Maintain the adequate airway oxygen therapy and ICP by the following measures. Minimal IV fluid to maintain the adequate intravascular volume. Ideally, the total IV fluid should not be exceed more than 80% of the fluid maintenance. Switch to colloid solutions earlier if the hematocrit continues to rise. A large volume IV is needed in cases with the severe plasma leakage. Administer a diuretic if indicated in cases with the signs and symptoms of the fluid overload. Positioning of the patient must be with the head up 30 degrees. Early intubation to avoid the hypercarbia to protect the airway, and may consider steroid, so circular steroid, to reduce the ICP is the intracranial pressure. And dexamethasone 1.5 milligram per kg per dose IV to be administered every 6 to 8 hours. Decrease ammonia production by the following measures: lactulose, local antibiotics, gut flora if not necessary to systemic antibiotics, maintains the blood sugar, correct the acid base, anticonvulsants, transfuse blood, empiric antibiotic, H2 blockers, and consider plasmapheresis. But the summary talk that I'd like to say, my dear, the encephalopathy. What I said, the encephalopathy. In dengue encephalopathy, the only one indications of steroids or dexamethasone in dengue is a steroid. Only indications of steroid in dengue is a yes, there is the encephalopathy. Dengue encephalopathy. There is the dexamethasone 0.15 milligram per kg per dose IV to be administered every 6 to 8 hours, along with the supportive measures. Types of the fluids required for the intravenous therapy. Fluids recommended are the following fluids: crystallized and cold crystallized and colloids are. And some of the precautions in order to ensure the adequate fluid replacement and avoid fluid over infusion, the rate of intravenous fluid should be adjusted throughout the 24 to 48 hours period of plasma leakage by periodic packed cell volume determinations and frequent assessment of the vital signs. The volume of fluid replacement should be just sufficient to maintain the effective circulation during the period of plasma leakage. Excessive fluid replacement and continuation of the longer period after cessation of the leakage will cause respiratory distress from massive pleural effusion, ascites, and pulmonary congestion or edema. This may be dangerous. Remember that the 1 milliliter is equal to 15 drops in standard macro infusion set. In micro system, micro burette infusion, 60 drops are equal to 1 milliliter. It is advised to procure only a bag of 500 milliliter initially, and order more as and when required. The decision about the speed of fluid should be reviewed every 1 to 3 hours. The frequency of monitoring should be determined on the basis of the condition of the patient. The higher the flow rate, the more frequent should be the monitoring. It is needed to be careful about the adequacy of the fluid flow rate, as high fluid flow rate may require appropriate adjustment of the fluid administration set, height of the saline stand, and sometimes the positive pressure application by sphingomanometer cuff around the fluid bag. Some important notes in the pitfalls and special concerns and checklist. Regarding the pitfalls, the failure to suspect the dengue infection in febrile patients with a history of travel to dengue endemic areas within 2 weeks of the onset of illness. Failure to suspect, identify, and treat the possible diseases such as meningitis or malaria. Failure to admit the patients with the signs and symptoms of intravascular volume loss or intravenous hydration. Failure to administer appropriate fluids. 2. Patients with the dengue hemorrhagic fever or dengue shock syndrome inappropriate. Failure to refer the transfer potentially critical or critical patients to better facility in time. Failure to notify public health authorities about suspected cases of dengue infection. Special concerns of older peoples. Here's the circle. Older, those with the congestive cardiac failure must be given excessive amounts of, must not be given, excessive amounts of IV fluids. Rare cases of the vertical dengue transmission have been reported. Dengue should be suspected in pregnant patients with comparable clinical features, but potential for neonates to be born with the signs and symptoms of dengue fever should be anticipated. Checklist: cases of dengue hemorrhagic fever should be observed every hour. So dengue hemorrhagic fever every hour. Serial platelet and packed cell volume should be dropped for platelet, and rise in packed cell are essential for early diagnosis of dengue hemorrhagic fever. Timely intravenous therapy, isotonic crystal isolation, may prevent the shock and lessen the severity. Be careful about the temperature of the fluid to avoid the chills and rigor. If patient's conditions become worse despite the 10 milliliter per kg per hour, replace the crystal isolation with the colloid. So here's the detour: the 10 to crystal to colloid dextran or plasma as much or as soon as improvement occurs, they replace the crystalloid. Preferred dose colloid is 10 milliliter. If improvement occurs, reduce the speed from the 10 to 7, 7 to 5, 5 to 3, 3 to 1.5. Already we learned 1.5, 3, 5, 7, 10. If hematocrit falls, give the blood transfusion 10 milliliter per kg, and in case of severe bleeding, give blood transfusion. In case of shock, give oxygen. Correct acidosis means ABCS, and check for another concomitant. Don'ts. These don'ts are really important. So the don't give the aspirin or NSAIDs for the treatment of fever. Avoid giving blood transfusion, platelet concentrate unless hemorrhage and bleeding fall in hematocrit or severe bleeding. Do not use antibiotics. Do not change in infusion rate or fluid rapidly or abruptly. Avoid rapidly changing, increasing, or rapidly slowing the infusion rate of fluid. Insertion of the nasogastric tube determine the concealed bleeding, and once again, to stop the bleeding is not recommended since it is hazardous. Avoid intramuscular injections and avoid tooth brushing in presence of gum bleeding. Role of steroid. Basis of dengue hemorrhagic fever pathogen is hypothesized to be immunologic. There is tempting for immunomodulatory drugs where therapy most common of which is steroid, but it is found that there is no beneficiary role of steroid, rather it is harmful. Yes, right, and therefore not recommended in the management of dengue fever or dengue hemorrhagic fever. Is a good medical practice for therapy. Yes, my dear, the role of steroid, there is no beneficiary effects, rather it is harmful, shouldn't and is not recommended. Only indications of steroid that we learned, there is the dengue induced encephalopathy, where then we can use, there is the dexamethasone as the dose. You see the steroid or dexamethasone in case of dengue encephalopathy. So this is a special checklist and role of steroid. And good medical practice: always collect and check necessary appliances before proceeding the IV puncture, and use the gloves to protect yourself and mask to protect the patient. Wash hands and antiseptic. For IV intravenous, choose a vein site, preferably use cannula having a wider bore. Insert the cannula, don't keep the cannula extravasation. Always check. And yes, this is some of the intravenous therapy, good medical practice. And you need to see special clinical situations: dengue fever or dengue hemorrhagic fever, the conditions that already are the concurrent illnesses or comorbid diseases or situations where demand the special situations, even in the well-equipped hospitalized or special centers. These are really important: the pregnancy, labor, elderly patients, infant, mandatory surgery, chronic liver disease, chronic kidney disease, cardiac diseases, heart failure, ischemic heart disease, hypertension, diabetes, dengue, and patient on steroid therapy and fluid hypoxia and anaphylaxis.